Good evening, everyone. Welcome and thank you for joining today's webinar. My name is Liam Winters, Manager of Development and Professional Outreach at the Facial Pain Association. Tonight, we're thrilled to host Dr. Mudagal and Dr. Melvin Field of Advent Health for Facial Pain, a multidisciplinary approach to care. Managing trigeminal neuralgia successfully demands a collaborative approach, and tonight our presenters will break down the complexities of facial pain, showing how a comprehensive, multidisciplinary model seamlessly connects clinical diagnosis with advanced treatments and surgical interventions to optimize patient care. I'm really grateful all of you have taken the time to join us tonight. This webinar is being recorded and will be added to the webinar library on our website later this week. We'll also send an email to all attendees and registrants, as well as those who registered but weren't able to attend the live event that contains a link to this recording. Before we begin, just want to share some updates from us here at the FBA, go over a few housekeeping items. First, I'd like to highlight our facial pain registry, which we launched in partnership with the National Organization for Rare Disorders on their I Am Rare platform. The registry provides a vital platform for people living with facial pain to share their experiences. By collecting this invaluable data, the registry can help drive medical discoveries. By contributing your story, you'll play a crucial role in helping researchers gain deeper insights into the true impact of facial pain, ultimately paving the way for improved patient outcomes. Your data is well protected in the registry, and your unique experience is very important. Um, Also, just want to say a special thank you to Advent Health for partnering with us on this webinar. We're really grateful for their support and their expertise here tonight. Now, just to go over a couple housekeeping items before we ask the doctors to kick it off. If you got any questions, please use the Q&A feature at the bottom of your Zoom screen. We'll have a dedicated Q&A session at the end, but please feel free to submit questions throughout the presentation. We also encourage you to connect with other attendees using the chat feature. A lot of people often ask questions over in the chat, and that's fine, but it's easier to capture all of them if they're in the Q&A box. Now, without further ado, it is my honor to pass along to our speakers that everyone came here to hear tonight. Let them say a bit more themselves and let them take it away. I'm just going to share my screen here. Alrighty, doctors, all on you.
Well, thank you, Liam. And hello, everyone. I'm excited to be here, and I'm excited to talk about trigeminal neuralgia and facial pain. And I think that this is a very important topic and a very exciting topic we need to discuss today. Next slide. So not every facial pain is trigeminal neuralgia, and not every trigeminal neuralgia patient presents the same. So it's extremely important that we review the differentials and the different causes of facial pain, since ultimately the trigeminal neuralgia is a clinical diagnosis. Also want to emphasize that this is an extremely painful and debilitating disorder. So imagine experiencing a pain that is so severe, a simple smile or a sip of water or gentle touch feels like an electric shock. And so it's extremely important that we make this diagnosis early on and provide appropriate treatments. Also want to allude to the fact that the treatment of trigeminal neuralgia is not all siloed. It requires multidisciplinary and integrated care, and with several subspecialties, including neurology, neurosurgery, pain management, dentistry, and primary care. So in this talk, we are hoping to cover some of the important differentials for trigeminal neuralgia, and also discuss the stepwise approach to management of these patients. Next slide. Next slide. So, like I said, we can go over some of the the features of trigeminal neuralgia, what are the medications to use, and when do we phone a friend, when do we get our neurosurgery colleagues involved, and other subspecialists involved. Next slide. So this slide suggests multiple causes of facial pain that we would consider when you're taking a history from the patient. And I probably look at it. Is it coming from within the oral cavity? Is it a dental issue, or is it more of an extraoral issue? Is it related to a nerve disorder? I know trigeminal neuralgia is the hero of our talk today, but is it also coming from musculoskeletals? Is it coming from your neck, or is it a headache disorder that is presenting as a facial pain? And further along, we'll talk about the different ways that we can differentiate trigeminal neuralgia from all of these other conditions. Next slide. So before we go on to talk about this patient that I saw in the clinic, I want to give you a brief idea regarding the anatomy of the trigeminal nerve. So the trigeminal nerve is the main nerve that carries the sensation from your face to your brain. You can think about it as a highway that carries these pain impulses. So the nerve starts in the brainstem, and then it travels to a small relay station. We call that the trigeminal ganglion, and then it divides off into 3 branches. And what you're seeing here in the color-coded formats, you have the V1, which is this yellow division of the trigeminal nerve, and then there's the V2, and then the V3 divisions of the trigeminal nerve. So this is our patient. So this is a 61-year-old right-handed female presenting with a 9-year history of right-sided facial pain that's progressively worsened over time. Saw her 2 years ago. The episodes were intermittent. She had several pain-free days. And more recently, the episodes have been more clustered together. She describes these as electric shock-like, lightning bolt-like pain, mostly in that V2, V3 distribution kind of phase. She tells me that the symptoms are precipitated by innocuous stimuli, so just heat, cold, wind, brushing her teeth. She looked very disheveled just because she was not brushing her teeth. She didn't really have any makeup on the right side of her face because the touch would stimulate the attacks. And sometimes the painful episodes were accompanied by contraction of those jaw muscles for the tictoroides. It's a symptom that can happen with trigeminal neuralgia. Next slide. So I've created a mnemonic for some of the symptoms that we see here. You can take it or leave it, but I think it's pretty nice. Talks about some buzzwords that we discuss with our patients. So the lightning like pain, innocuous triggers, goes fast, half the face, typically unilateral, involves mostly the trigeminal territory. Typically no sensory loss. We'll talk about this. It can be a little different with symptomatic or secondary trigeminal neuralgias. Intermittent paroxysms, usually not explained by another disorder, grimace inducing. Next slide. So definition of trigeminal neuralgia. So again, to go over this, it's recurrent paroxysms of pain, which is typically unilateral. It's usually one side of the face. Sometimes it can be bilateral, but typically in the distribution of the trigeminal nerve. And the pain episodes are brief, typically lasting for a few seconds up to 2 minutes. They're very, very severe in intensity. The quality of pain is typically that electric shock-like, shooting, stabbing, sharp quality. And the triggers are always triggered by innocuous stimuli. So stimuli that shouldn't be painful trigger severe pain. Next slide. So trigeminal neuralgia is actually relatively rare. It is not as common as we think. The annual incidence of this is about 25 cases per 100,000 people. And at any given point, you might have about 45 in 100,000 having trigeminal neuralgia, which is often the reason why it's not on top of the differentials there. So approximately, you'd say the lifetime prevalence, so maybe 1 in 1,000 who develop it at some point in their life. It is much more common in women than in men, and usually involves the V2, V3 distributions. It's usually less common in that V1 distribution. Next slide. Trigeminal neuralgia is uncommon in individuals under the age of 40, but then it starts to rise somewhat in the 4th decade, but mostly in the 5th to the 7th decade of life. And overall, you can see that the incidence is much more common in women than in men. And with advancing age, that difference narrows. And then in the older population, the prevalence almost becomes similar or maybe slightly higher in men. Next slide. So we'll go over some of the differentials and lookalikes for trigeminal neuralgia, and this is extremely important to recognize. And with each of these, uh, maybe we can try to focus on the quality of the pain and the triggers, because that's what gives away the diagnosis. So with temporomandibular joint pain versus trigeminal neuralgia, you can imagine with the TMJ, the process typically affects the temporomandibular joint, and muscles of mastication usually happens on one side, sometimes it can be both sides. And it's mostly triggered by chewing or jaw parafunction, like bruxism that we see in patients. And the pain can be provoked by passive movements of the jaw. Sometimes you hear patients telling that they feel like the jaw's popping or clicking, and sometimes you can feel the crepitus with the jaw movement. Another close mimicker of the trigeminal neuralgia is what we call atypical facial pain. Now, the terminology is changed to persistent idiopathic facial pain. And this is a very poorly localized pain. Again, the quality, it's like a dull, nagging, aching quality. And it's usually aggravated by stress. And it can occur outside of the trigeminal dermatome. So sometimes it spans kind of more the craniocervical region, kind of in the neck, in the face, in the head. So it's not just the trigeminal region, and it's again more common in women and associated with psychiatric comorbidities and other chronic pain syndromes. Next slide. So the headaches are a very close mimicker to trigeminal neuralgia, especially the migraines and cluster headaches. And I can talk about these all day because this is what I really do in clinical practice. But the trigeminal nerve the neuralgia is due to a dysfunction of the trigeminal nerve, and it's the same nerve that's implicated in the pathology of migraine or cluster headaches. In migraine, it is more of a neurovascular phenomenon, so you have the involvement of blood vessels as well, and so you get that pulsating quality to the pain, and the pain is typically in the head. It's usually more on one side, it's unilateral, throbbing, pulsating quality. In about 50%, it can be bilateral. And the duration of symptoms, it's not seconds or minutes like in trigeminal neuralgia. It's usually lasts long. So it usually lasts about 4 to 72 hours in duration. Sometimes it can last longer than that. And it may be associated with other symptoms such as sensitivity to light, sensitivity to sound, sensitivity to smell. So it's a very different presentation than trigeminal neuralgia. The reason it gets confusing is sometimes you can feel the migraine in the face just because of the nerve supply and the anatomical distribution. So you may have the headache that kind of radiates into the face, and then it kind of clouds the diagnosis. The cluster headache is another kind of a headache disorder. It's a primary headache disorder where you have pain behind the eye, in the temple. It's a very severe piercing pain. Again, lasts for minutes to hours, usually 15 minutes up to 3 hours in duration. And there are usually a lot of autonomic symptoms with a cluster headache: tearing of the eye, ptosis, drooping of your eyelid, runny nose, pupillary changes, decreased sweating on one side of the face. And the patients are very restless. They're pacing during these attacks. And they happen in clusters. So they happen for a few weeks at a time. They go away and then they come back again for a few weeks. And typically, they have a seasonal variation. They wake up the patient at night. They're nocturnal. And it's almost called an alarm clock headache because it wakes them up at the same time every day during the attack phase. So again, very different. Unlike trigeminal neuralgia, which is just a few seconds to minutes, this usually lasts minutes to hours in duration, and a lot of those autonomic symptoms that can be present. Next slide. So another close differential to trigeminal neuralgia is trigeminal neuropathy. And what neuropathy means is mostly damage to the trigeminal nerve. So again, this is a continuous or near continuous pain. So again, the quality of pain is very different. It's a dull, burning, squeezing kind of pain. Almost sometimes they tell you it feels like a pins and needles sensation. And although you may have some paroxysms on top of that, it's usually not the predominant pain type. And most importantly, with trigeminal neuropathy, there can be some sensory abnormalities. Patients may experience sensory loss, so numbness in the face. There can be increased sensitivity to touch or cold. And so that helps differentiate it from the trigeminal neuralgia, which is kind of more of that paroxysmal pain. Next slide. So dental pain, again, we oftentimes see patients that have already seen their dentist because a lot of the pain affects the teeth, the jaw. And so they already had their dental evaluation before they see us. Again, it's a very aching quality of pain. It's triggered by biting, chewing on the food. And there's a condition that we call atypical odontalgia, where you can have a continuous pain in the area of the teeth without, usually after a tooth extraction, and there isn't an identifiable cause. And so some of that can cause that nagging pain that we see in these patients. Next slide. Another thing that can easily be confused with trigeminal neuralgia is a cervical myofascial neck pain, and you can imagine how pain in the neck can sometimes radiate into the head and into the face. And so there could be structures in the neck, including the muscles, the joints, the soft tissue, that can trigger the pain. And most importantly, it can be triggered. So you can provoke this pain with neck movement or palpation of the cervical muscles or the pericranial muscles that can produce the patient's symptoms. And oftentimes they have a headache component with this as well. Next slide. So we know that trigeminal neuralgia is primarily a clinical diagnosis, and it's based on getting a good history and examining the patient. However, a classification system can be helpful because it will help identify the underlying etiology and also give us an idea on what are the treatment options the patient might have and what the overall prognosis looks like. Next slide. So broadly, the trigeminal neuralgia can be classified into classical trigeminal neuralgia, which is typically related to neurovascular compression. There could be a secondary trigeminal neuralgia, which there could be an identifiable cause for the symptoms, such as the tumors or multiple sclerosis or connective tissue diseases, arteriovenous malformations, AV fistulas. And then there's a third bucket where the MRI and electrophysiological studies are normal, but patients still experience the classic symptoms of trigeminal neuralgia. It's called idiopathic trigeminal neuralgia. Next slide. So I'll talk a little bit about the pathology of the neurovascular compression that we see here. And this is what happens with classical trigeminal neuralgia. So you see a blood vessel that is encircling and compressing the trigeminal nerve. And when it does that, it disrupts the myelin, which is the insulation on the nerve, and causes what we call focal demyelination. And that makes the nerve hyperexcitable. There is abnormal electrical activity. There's ectopic impulse generation, crosstalk between the nerve fibers, making a response such as touch painful. And so we call that aphatic transmission. And so overall, there is hyperexcitability in the neurons and the sodium channel dysfunction. Over time, that can result in central sensitization and altered pain processing within the central nervous system, and which can amplify and perpetuate symptoms of trigeminal neuralgia. Next slide. So what clinical features identifies patients as having a secondary trigeminal neuralgia? So certain clinical features that should raise concern include younger age of onset, usually less than 40, bilateral symptoms, or presence of sensory abnormalities on exam. When you have these three features, your clinical suspicion for secondary etiology should go up. Next slide. The diagnostic testing for trigeminal neuralgia, like I said before, the trigeminal neuralgia is most commonly a clinical diagnosis, and testing can be helpful to evaluate for secondary causes or know what the etiology is. There are two different tests that we can use. Most commonly, the most common test we use is an MRI, but sometimes when MRI is contraindicated or inconclusive, then we could use electrophysiological tests as a mean to tell whether it's classical or secondary trigeminal neuralgia. Next slide. So these are some clinical studies looking at classic and secondary trigeminal neuralgia. Uh, the test that they use here is a blink reflex test, where they stimulate the V1 and look for contraction in the orbicularis oculi muscles, and they stimulate the V2, V3 and look for contraction in the masseter muscle. And so sometimes prolonged latencies or abnormal responses could suggest a trigeminal pathway dysfunction and suggest secondary trigeminal neuralgia. So it is pretty sensitive to pick up secondary etiologies. Next slide. Another test that commonly is used well, uncommonly used, I would say, is the evoke potentials, where you stimulate the trigeminal nerve and that generates cortical responses, and you can record that via EEG. And so when there's neurovascular compression, there is delayed signal transmission, there's abnormal evoke potentials. And when you reverse the neurovascular compression, there is improvement in these electrophysiologic findings. Next slide. So again, this is looking at the sensitivity and specificity of the evoke potentials. It's not highly sensitive or specific, but it can tell you that there is some demyelination happening, and it needs to be looked at. Next slide. So if MRI is contraindicated, the trigeminal reflexes can help distinguish classical from secondary trigeminal neuralgia, and evoke potentials may be associated with abnormal trigeminal nerve dysfunction. Next slide. MRI remains to be gold standard in patients who have no absolute contraindications. It's extremely important that we obtain high resolution imaging in the evaluation of the trigeminal neuralgia. A 3 Tesla MRI is typically preferred because it provides better visualization of the trigeminal nerve and the surrounding structures. And it's also equally important to request for appropriate imaging protocols or sequences. Most institutions use KISS or Fiesta sequences, and that gives us very good idea about the cranial nerves. If not entirely sure what to request, you could put in the comments to obtain thin sections imaging through the trigeminal nerve, and that hopefully should prompt the radiologist to use the appropriate protocol. In some cases, MRA may be obtained to look for the vascular loops. In contrast enhanced MRI is typically preferred since we are looking for secondary etiologies and trigeminal neuralgia. Next slide. Next slide. So this is a slide looking at different sections of the trigeminal nerve on the left side. You see the trigeminal nucleus complex in the brainstem, the level of the pons. The red dot here indicates the motor nucleus. The green dot indicates the sensory nucleus there. It branches outside the brainstem. You have the cisternal segment of the nerve where it gets compressed and then goes to trigeminal ganglion and divides into 3 major branches. So in the slide below, you can see that there is some demyelination here on the right side. It's the arrow pointing to the area of abnormality. There's a patient who had MS who came in with right-sided facial numbness, and MRI showed this demyelinating plaque right there. Next slide. So here on the left side, it's a pictorial representation of the neurovascular structures. You see the blood vessel in red compressing the trigeminal nerve in green. And in the middle section here, slide below, you can see the blood vessel actually pushing against the trigeminal nerve and compressing it and deforming the nerve. So the yellow arrow indicates the round structure, the round black structure you're seeing is the blood vessel pushing against the trigeminal nerve. On the extreme right side, you can obviously tell that there is a lesion here that's in the cerebellopontine angle that's pushing on the trigeminal nerve and causing symptoms. Next slide. Again, as the trigeminal nerve exits the brainstem and enters into the Meckel's-cave, there could be pathologies around the Meckel's-cave on the right side that you're seeing on the MRI that could cause these symptoms. The slide below, you're looking at the nerve as it exits into the cavernous sinus. And you can see some pathology kind of in that lateral wall there. On the right side on the MRI, you can see some dural thickening over, that could possibly be causing trigeminal nerve dysfunction. Next slide. So what are the treatment options for trigeminal neuralgia? So there are several treatment options. There are medical therapies, there are neuroablative procedures, there's surgery that Dr. Field will talk about, neuromodulation. Um, I'll focus my talk on the medical treatments for trigeminal neuralgia. Next slide. So the first line treatments for trigeminal neuralgia involves anticonvulsant medications, primarily carbamazepine and oxcarbazepine. These agents, they act by blocking the voltage-gated sodium channels, and so they reduce the neuronal hyperexcitability and prevent propagation of those pain impulses. Both medications are pretty effective. Uh, Carbamazepine is most well established, but it is oftentimes less well tolerated. And most common side effects include dizziness, ataxia and coordination. In patients of Asian ancestry, we do recommend HLA-B 150 testing to look for the presence of allele, which can significantly increase their risk of Stevens-Johnson syndrome. Oxcarbazepine is generally better tolerated than carbamazepine, but it's most commonly associated with hyponatremia, which again can be a dose-dependent side effect. In some routine lab tests I recommend in patients on antiepileptics is getting a CBC looking for any cytopenias, liver function tests, serum sodium levels. We also need to remember that carbamazepine is an autoinducer, and so the efficacy seems to decrease over time, resulting in the need for dose escalation. Next slide. The second line medications that can be considered include lamotrigine. Again, this is a sodium channel blocker. Again, you start with a low dose and slowly taper up the dose as tolerated. Baclofen might be quite effective, especially if used in patients with MS because they also have spasticity, so it can help with that. Again, they can be pretty sedating with side effects of drowsiness and coordination. So we have to be mindful on how much we are using, especially in older individuals. This can be pretty disabling. Next slide. For patients who have the background continuous pain, I do recommend using neuropathic agents such as gabapentin and Lyrica. Now, most patients with trigeminal neuralgia present with a paroxysmal pain, but sometimes they may have a concomitant continuous pain between the paroxysms as the disease gets worse. And so in those individuals, I oftentimes add gabapentin or Lyrica to carbamazepine to help give them some better symptom control. Next slide. So this is, next slide. So another treatment modality we use for trigeminal neuralgia is botulinum toxin. It's an off-label treatment for this condition. It was used back in the day, back in 2002, was first identified for use in trigeminal neuralgia, and then there have been several randomized control trials that have shown that Botox can be pretty effective with over 50% reduction in pain severity. There have been some systematic reviews that suggest at least a 60 to 70% improvement in those pain scores. The attack frequency is significantly reduced in patients who receive the Botox. And generally, patients who have classical trigeminal neuralgia tend to respond better, or if they're unable to tolerate antiepileptic medications, or if they have refractory symptoms, this might be a treatment of choice to consider. Or while they await surgery, if they want some symptom control, then Botox may be offered in that situation. Next slide. Nerve blocks can also be quite effective in the treatment of trigeminal neuralgia. It's oftentimes used as bridge treatment. We can use lidocaine, sometimes we can use bupivacaine, just in the trigger zone areas, and that can be effective. But as you can see in this graph, the efficacy tends to go down over time. So by 6 weeks, you can see. So this is a baseline, and then the graph shows you at about 6 weeks, you can see that those pain scores climb up again. So the effect isn't really long lasting, but it can be quite effective while waiting surgical treatments. Next slide. So for acute symptomatic relief, things that I would consider are topical lidocaine, either a lidocaine nasal spray that can offer instant relief, the 10% lidocaine spray, or the topical cream at the trigger point, at the trigger zones. If they have coexisting migraine, I do utilize sumatriptan injectables that can be quite effective. In most severe or refractory cases, IV intravenous therapies may be utilized, and I commonly use IV fosphenytoin at 15 milligram per kg, and that usually, again, it's a sodium channel blocker. It provides that pain relief in some of those flare-ups. Um, I do recommend inpatient admission when they're unable to maintain adequate hydration or nutrition, and when there's a need for rapid optimization of their preventive treatments and pain control. Next slide. So some of the other treatments that have been effective for trigeminal neuralgia is oral lacosamide. This is gaining more use, especially in patients who are unable to tolerate the carbamazepine or oxcarbazepine. I do recommend monitoring EKG. I do recommend a baseline EKG prior to initiation because it may sometimes cause conduction blocks and bradycardia. So it's important to identify that before initiating lacosamide. There have been some newer medications such as fixotrigine. It's a sodium channel blocker. It only blocks the dysfunctional sodium channel, so we don't see a lot of side effects with that. Again, it's only in phase 3. It's not out yet. There's some glutamate receptor blockers that are being studied for treatment of trigeminal neuralgia, and erinumab, which is a CGRP receptor antagonist that we use commonly in migraine patients, that has been looked at in the treatment of trigeminal neuralgia as well. Next slide. So clinical pearls, carbamazepine and oxcarbazepine are usually the first-line treatments for trigeminal neuralgia. There are some second-line treatments that may be considered. Lacosamide may be used in refractory patients. Next slide. Botox may be considered when some of these other treatments are ineffective. Nerve blocks using lidocaine or bupivacaine may be effective for short-term relief. And for acute exacerbations, IV lidocaine or phenytoin may be considered as well. Next slide. So when do we refer to neurosurgery, right? So when patients fail or poorly tolerate medications, or if they're experiencing adverse effects to standard doses of the medications, or if I see abnormal imaging, so if I see the tumors or vascular malformations and things like that, I make a referral to neurosurgery. And most importantly, when there's loss of sensation or other neurological deficits, it kind of keys me into a secondary cause for trigeminal neuralgia. So initiate the referral early on, get the patients established with neurosurgery early on to have that conversation about some of those treatment options that they may have. Next slide. This is the last slide. It talks about a multidisciplinary pathway here, starts with primary care. You see a dentist, neurologist, pain management, neurosurgeon, psychiatry. So, like I said, the treatment isn't siloed. You have a lot of subspecialties involved. And with that, I'm going to pass this over to Dr. Field.
Great. Thank you. Can we go to the next slide? Next slide, please. So, hi everyone. I'm Dr. Field. I'm a neurosurgeon who works primarily at Advent Health, and I've had an interest in trigeminal neuralgia and neurovascular compression syndrome since the early 1990s, when I had an opportunity to work with a guy named Albert Roten at the University of Florida. And as a medical student, I got to see a case of trigeminal neuralgia, and I became fascinated by it. And following that, I had an opportunity to work with a guy named Dr. John Tu, who's the person who basically pioneered trigeminal rhizotomies when he was at the University of Cincinnati. And then after that, I was very blessed to be able to work with a guy named Peter Janetta. And as many of you may know, he's considered the father of trigeminal neuralgia. And I got to spend quite a few years there learning how to treat this picture that we see right here. And as a neurosurgeon, this is what we consider to be trigeminal neuralgia. It's usually a process that is causing compression of the trigeminal nerve. Now, there are exceptions for people with autoimmune and inflammatory conditions such as multiple sclerosis. You can get demyelinating plaques that can cause face pain, known as symptomatic trigeminal neuralgia. But for us, classical or type 1 trigeminal neuralgia is what we as neurosurgeons get most excited about treating because we have a real opportunity to get rid of the pain in a lasting and meaningful way. This picture that you're looking at here is actually an endoscopic view of someone's posterior fossa. And at the bottom of the screen, you're actually looking at the pons of the brainstem, and that white thing coming out of it is the trigeminal nerve. The brighter red object is a blood vessel that is the superior cerebellar artery, compressing and actually knuckling into the nerve. And then on the other side of it is a vein. That's the petrosal vein, which is basically sandwiching the nerve and causing the patient to have their pain. Can we go to the next slide? So we'll talk about trigeminalgia, but I also wanted to bring up a couple of other disorders we'll talk about tonight, such as glossopharyngeal neuralgia or what I call nervus remedius neuralgia. These are disorders that are even more uncommon than trigeminalgia. They often are misdiagnosed as trigeminalgia, but they're actually disorders due to compression or irritation of adjacent nerves that can also affect the head. Can we go to the next slide, please? So we talked already a little bit about medications and Botox injections, and I'm going to talk more about the neurosurgical treatments that we have to offer trigeminalgia. And as a general rule, these treatments are going to be most effective for people that have trigeminalgia due to a lesion compressing the trigeminal nerve. In people who don't have a blood vessel or tumor pressing on the nerve, these treatments are not going to be as effective, although there is some variability of effectiveness with them. For example, patients with multiple sclerosis can get relief with Gamma knife or what we call radiosurgery or with rhizotomies, rarely with neurectomies. So they can be applied to people without neurovascular compression, but they're most successful in people with neurovascular compression. Next slide, please. So when do we do these? Well, essentially when medical therapy fails. So initially, most of our patients will see a dentist. They've ruled out a dental source. They've ruled out a TMJ etiology. They've been seen by neurology. We've made sure this is not due to MS or zoster, which is a type of infection due to the herpes virus. We make sure that this is not due to some kind of trauma to the nerve where there's deafferentation and they have numbness and burning and throbbing and aching as opposed to the stabbing, shooting electrical pain that is common with trigeminalgia. And when these medical therapies fail, that's when they often will come to see us. From a neurosurgical perspective, we tend to break these into two major categories. Those which I call ablative, meaning they are procedures designed to damage the nerve in an attempt to get rid of the pain. And then those that we call restorative, where we're not trying to damage the nerve, we're trying to fix the underlying cause that is irritating the nerve. And that's the microvascular decompression surgery. Next slide. I'll start with the ablative procedures, and the oldest of those are what are called trigeminal rhizotomies. These are procedures where, under light sedation, the neurosurgeon will place a needle essentially into your cheek, as you see on the right image here. This is an X-ray, where that needle is essentially going all the way to where the trigeminal nerve comes out of the skull. It's in what's called the Caesarean ganglion. And through that needle, we're going to do something to damage the nerve. We're either going to burn the nerve with heat, we're going to inject a neurotoxin into the nerve, or we're going to inflate a balloon to compress the nerve. Generally, these procedures are designed to try to damage the pain fibers of the nerve and not damage the other fibers of the nerve if possible. Next slide, please. This was a slide that I actually stole from one of my friends, Dr. Kaufman, who's up in Winnipeg. He also trained with me when I was in Pittsburgh. But this is basically showing the three types of rhizotomies that can be done. On the bottom right, this is a radiofrequency rhizotomy where you have a heat generator that is going to burn the nerve in an attempt to get rid of the pain. In the middle, this is called a balloon compression rhizotomy, where you inflate a balloon to compress the nerve. And then on the right is the glycerol rhizotomy, where you inject this neurotoxin to the nerve to try to damage it. They all work a little bit different. At the end of the day, the success rate with them is very, very similar. And quite honestly, which one of those is offered to you by the neurosurgeon most commonly is related to where they trained in what part of the country. So the radio frequency is more developed kind of in the central US and southern US. The balloon compression is something that was more popular over in the Northwest California. and in some areas of the Northeast, and then glycerol basically was also popularized in the Pennsylvania area. Next slide, please. Another ablative procedure that we have is called radiosurgery. The most common form of that is called gamma knife. But there are other forms of radiosurgery as well, which we call LINAC or linear accelerated radiosurgery or cyberknife radiosurgery. And our literature shows that these technologies are very similar. Gamma knife has been done most frequently and has the longest track record, but any one of them could be used to treat someone with trigeminalgia. These are procedures where a patient lays in a machine and they aim radiation at the nerve. These usually take about an hour or so to do. It's outpatient. You can go home that day. You don't have to stop any medications in order to have this procedure done. You don't have to be of top shape in terms of being healthy, in terms of getting them done. And most patients actually find the experience very well tolerated. The one drawback of these procedures, though, is they don't work immediately. They take some time to work. So when you leave the Gamma Knife Center after having the procedure, you're still going to have your face pain. You still need to stay on your medicines. But generally, after several weeks, a patient will start to notice some improvement of their pain. And a majority of patients within 6 months have had significant improvement of their pain from these procedures. Next slide. When we do the Gamma Knife, it's generally a single treatment. The accuracy of the radiation is less than a millimeter. So people are always worried about losing hair or getting dementia or other problems related to it. And the dose of the Gamma Knife is very, very, very precise. So it's not going to cause those issues. And again, it doesn't require anesthesia, and people can go back to their regular activities later that day. Next slide, please. This is the frame that everybody fears when we do Gamma Knife. Basically, the patient are given some sedation, and we apply this frame so that we're able to precisely localize the radiation. Next picture, please. And this is just a picture where a patient has had an MRI. These dots that you see around the head, that is that box you saw in the previous image. And then the arrow is showing the trigeminal nerve. And on the right, it shows where we're aiming the radiation to treat the nerve. Next slide. This is what the current Gamma Knife machine looks like. So you can see it's open. If you have claustrophobia, it's not an issue with the Gamma Knife because it's open. It doesn't make any noise. It's actually pretty comfortable. Most patients fall asleep during the treatment. Next slide. And then the last treatment that neurosurgeons often will talk about is the microvascular decompression. This is not designed to cause any damage to the nerve. Rather, it's designed to get rid of what's causing the nerve pain altogether. Next slide, please. So when people read about microvascular decompression, they hear that the surgeon's going to drill a hole in their head, and they're very worried about the hole. This is actually an image of one of our surgeries, and this is the hole that's made. So you can see it's about 1 inch. Most people actually have holes in their skull already that are larger than this. The base of your skull, called the foramen magnum, where the brain connects to the spinal cord, that opening is actually 3 times this size. So it's a relatively small opening that we make. Next slide, please. And we do these with what's called endoscope assistance. So this is an endoscopic camera that goes into this opening and allows us to help visualize the nerve and what's compressing it. Next slide, please. This is a monitor that we have in the room, and it's magnified several fold. And you actually can see that there's this space in here. So another misconception is that we're operating through your brain. And when we do these procedures, we're not actually operating through the brain. We're operating in the skull, but we don't go through any kind of brain tissue in order to get to the area where the nerve is being compressed. We actually are coming around the brain to get to where the trigeminal nerve is located. And thus, it's minimizing any kind of damage to those structures. Next slide, please. Can you hit play on this? This is a video that we developed several years ago to basically describe it. You can go online and see actual surgeries if you want, but I find that lots of patients have a hard time with all the blood and gore. So we actually made a cartoon to show it. So we make a small incision that goes behind the ear. We make an opening about the size of a dime. Using an endoscope or a microscope, we then go around what's called the cerebellum in this space, which is called the cerebellopontine angle. And then what we do is we find the trigeminal nerve, as you see here. And in this case, you see a blood vessel. In this case, it's called the superior cerebellar artery. It's the most common blood vessel to press the nerve. And basically, all we do is we move that blood vessel off of the nerve. Usually, it has two loops. And then we put this cushion between the blood vessel and the nerve. We use what is called Teflon, but different people can use different materials. There are two ways in which this can be done. One is you can pad the nerve to separate the blood vessel away from it. And the other way is you can just move the blood vessel away and kind of cinch it in place without compressing the nerve. And then when we're done, we close the incision and we wake you up. It usually takes about an hour and a half to 2 hours to do that procedure. And most people are in the hospital for about 2 days. The one nice thing that we like about that procedure is that, well, depending on the center, the likelihood of pain relief is immediate in most patients, and the likelihood of it coming back is lower than with the other procedures, and the risk of numbness in the face is also lower. Next slide, please. So when we look at the results, in terms of all these different treatments we've talked about tonight. Medications for people with trigeminal neuralgia, 75 to 90% of them will initially respond. And the medication that tends to be most effective initially is the oxycarbazepine or carbazepine, also known as Tegretol. What we do find with these medicines is that over time, people will start to have breakthrough symptoms. So initially, these medications work great. But then at some point in time, they have stopped becoming as effective. So either you have to increase the dose, or sometimes you have to add a second medication to help control the pain. And on average, these medicines will work for 5 to 7 years before they're no longer working. And of course, there's variation. We have some patients that within a couple of months, the medicines are no longer working. And we have other patients who have been on them for 20 years and are still doing great. So this is why we always start with medications. For the trigeminal rhizotomies, where we use a needle to try to damage the nerve, about 70 to 80% of patients will get some pain relief for that procedure, but almost all of them will have some degree of numbness from that procedure. When you are damaging the nerve, you invariably are going to cause some degree of numbness. And 50% of the patients, that's permanent. That treatment often will work for a period of time, but about 50% of people will note that the pain starts to come back within 3 to 5 years. You can repeat these rhizotomies, but each time you do it, there's a higher risk of getting more and more numbness. But the durability is usually about the same. The one concern we have about undergoing that procedure multiple times is eventually you can get a disorder called anesthesia dolorosa. And that's a pain disorder of the face where it's due to damage of the nerve as opposed to irritation of the nerve. Those patients describe numbness in their face, burning in their face, stabbing pain in their face, constant throbbing in their face. They often will say it feels like there's fire ants underneath their skin. And unfortunately, we don't have any good treatments for it. And the more treatments you have to damage the nerve, the higher that risk can occur. It's for that reason we don't do the rhizotomies as much anymore as we used to do back in the 1980s. Next slide. So for Gamma knife, for radiosurgery, about 70 to 80% of patients will have marked pain relief at 1 year. In fact, most of those patients within 6 months, and in many patients within 2 to 3 months. Um, if someone says they got pain relief within an hour of Gamma knife, they probably don't have trigeminal neuralgia because it doesn't work that fast. Some patients within a couple of weeks will get a response, and most of them within 6 months. The risk of developing the numbness from Gamma knife is about 15%, so much less than it is with the rhizotomies. And depending on the series, it can range anywhere between 5 to 35%, but it's going to be less than what you see with rhizotomies. About 30 to 40% of patients will have the pain come back within 3 years and 50% within 3 to 5 years. So if you're older and you're not healthy, it's not a bad treatment. It probably will provide some durable relief, but in all likelihood, if you're otherwise younger and you're going to be living for many years, Gamma knife will work, but at some point it will probably come back. You can do Gamma knife again, but if you have a second treatment, that risk of numbness goes up to about 50%. And if you have it a third time, that risk will go up to about 90%. So with each treatment, you're causing more damage to the nerve, so the risk of numbness goes up each time. And then lastly, from the microvascular decompression, which we consider to be the gold standard for trigeminal neuralgic care when medications are no longer working. In our series, about 90% of patients will wake up from surgery and the pain will be gone. The risk of numbness is between 4 to 9%. It's about 5% in our series. So most people don't get numbness from the surgery. The likelihood of it coming back is about 2 to 4% per year initially, and about 15 to 20% at 10 years. If you get 10 years out and it's not come back, the risk of it coming back is less than 1% thereafter. So it tends to be very durable. It can also be repeated if the pain comes back, but Again, with repeat treatment, the risk of numbness goes up. But generally, if you're otherwise healthy and medications are no longer working, this is the next step because it's the treatment most likely to get rid of your pain, least likely to cause numbness, and least likely to come back. Next slide, please. All right. For the remainder of our time, I wanted to talk about a couple of other disorders that are not very well known about. And I see patients probably every month that have one of these things, and for years have been told it's trigeminal neuralgia when it's not. And the first is called glossopharyngeal neuralgia. And this is similar to trigeminal neuralgia, but it's involving a different nerve. It's the nerve that provides sensation to the base of the tongue, the throat, the ear, and the base of the jaw. And what most of these patients will describe is severe stabbing, shooting electrical pain in the back of the nose, in the back of the throat, in the back of the tongue. Sometimes it's stabbing pain in the ear and the tonsils. Most of these people have also been to a dentist, they've been to a neurologist, and they'll be told this could be trigeminal neuralgia. The triggers for this, as opposed to light touch to the face, often with coughing or laughing or speaking or swallowing, they'll get the pain. But chewing and touching the face does not cause it. It's much less common than trigeminal neuralgia. It occurs about 1/100th of the amount of time that you see for trigeminal neuralgia. So for every 100 trigeminal neuralgia patients we see, one of them will actually have this disorder. And the treatment for this disorder is a microvascular decompression of this nerve, which is just as effective as surgery for trigeminal neuralgia. Medications can also be used, but radiosurgery such as gamma knife cannot be done, nor the rhizotomies. Next slide. There are things that can imitate glossopharyngeal neuralgia, and one of them is called Eagle syndrome. And this is where you have an elongation of what's called the styloid process. It's a bone at the base of your skull that can also irritate that nerve and cause almost very similar symptoms. So whenever we see someone that we think will have glossopharyngeal neuralgia, we will order this type of CT, the skull base, just to make sure this is not Eagle syndrome. If it is, we would send you to an ear, nose, and throat doctor, and they basically can just drill down this extra large piece of bone, and the symptoms will go away. Next slide. Nervous intermedius neuralgia is also known as geniculate neuralgia. It's also very rare. It's about 1/100th of as common as glossopharyngeal neuralgia, so very, very uncommon. There's only been a handful of cases reported, but I've seen 4 or 5 in my career. And it's a shock-like pain in the ear. So it's stabbing, shooting, electrical, paroxysmal pain in the ear, like someone stabbing you in the ear, and it comes and it goes, but it's just in the ear. Next slide. The triggers for nervous intermediate neuralgia are non-noxious stimulation of the ear, swallowing and talking, and between the attacks, patients are pain-free, and it's always unilateral. It's never on both sides, and it's also not constant. If you have constant stabbing pain in the ear, it's more likely a disorder of the Jacobson's nerve, and we usually will have you see an ear, nose, and throat doctor. Next slide, please. During attacks of nervous intermediate neuralgia, people can also notice increased salivation, a bitter taste in the back of their throat, sometimes ringing in the ears or vertigo. And the reason you can get the tinnitus or the vertigo is that there's a nerve right next to it called the vestibular nerve. It could also be irritated by the same thing that's causing the nervous intermediate neuralgia. Next slide. The treatments for this, similar to that for glossopharyngeal neuralgia, you can do medications, you can do a microvascular decompression, and in some cases, you can suction or cut that nerve itself to get rid of the pain. It will give you a numb eardrum, but that's much better than having a stabbing pain in your ear. Next slide. So this is an example of nervous intermediate neuralgia. Generally with a standard microscope, it's sometimes very hard to see. This right here is the vestibular cochlear nerve. Next to it is a small nerve called the facial nerve. And in between it, you see that there's this blood vessel between these fascicles of nerve. And in between the fascicles, there's this very little twig right where it comes out of the brainstem. And this is nervous intermediate neuralgia. If you look in the slide on the right, we've now zoomed this area up. And because we can't just move this blood vessel away because it's actually between these two nerves, and you'd have to cut one of those nerves to move that artery, what we did here is we actually cut the nervous intermedius nerve to help get rid of the pain. Next slide, please. And then lastly, there's some off-label treatments for patients that have persistent pain. So if you have face pain or throat pain or ear pain, atypical pain or neuropathic pain, meaning you've had damage to a nerve and none of these neurosurgical treatments are options for you and the medications aren't working, we can try forms of stimulation in the brain to try to get rid of the pain. These are off-label, and one of them is called cortical or cortical motor stimulation, where you basically put a pad of electrodes over the motor strip of the brain. You hook it up to an electrode and you stimulate that area to try to override those pain signals. This is usually done by a functional neurosurgeon. Next slide, please. Again, this is off-label. It's for people generally with neuropathic pain or failed conservative treatments. It won't cure the pain, but can decrease the severity by 30 to 60%. It does require two procedures, one of them where we implant the electrodes and another one where we basically implant what's called the pulse generator or the battery, which is usually done a few weeks later. And it does have some risk because you're stimulating the brain. There's a risk of seizures. It could affect speech if it's on the left side. And it can cause weakness because it's over what's called the motor strip. Next slide, please. Alternatively, we can do deep brain stimulation similar to what they do for Parkinson's patients. Basically, the stimulator electrode is placed into the brain in a part of the brain called the thalamus, or it could be placed in an area called the periaqueductal gray. And the duration of the response for this is also somewhat variable. And again, it's used for people that have failed all their treatments or have neuropathic pain, primarily in the top of the face. So the V1 distribution. Next slide, please. Again, it's off-label, and it, again, won't cure the pain, but does work in over 50% of patients to decrease the pain, and it can last for anywhere between 3 to 6 years after it's performed. Also requires two procedures, and the risk associated with this could be slurred speech, sometimes double vision, tightness or rigidity in the muscles, or new facial numbness. I would say those risks are relatively small, but they do exist nonetheless. Next slide. And then lastly is what are called spinal cord stimulators. So as noted earlier, the trigeminal nerve has signals that go into what's called the brainstem, and that trigeminal nucleus actually extends all the way into the cervical spine. And so there are some centers that have had variable response by putting the stimulator into the top of your spinal cord, trying to stimulate that trigeminal nucleus to try to get rid of the pain. And that generally is more helpful for people that have pain in their cheek and their jaw and what is known as the V2 and V3 distribution. Next slide, please. So for us at Advent Health, our algorithm for treating trigeminal neuralgia is confirm the diagnosis. So if we see someone we think that may have it, we make sure there's no dental source. We make sure it's not due to TMD. We make sure it's not to zoster or autoimmune or inflammatory conditions. And then once we've confirmed the diagnosis, next slide, we get an MRI to see if this is due to a tumor or due to neurovascular compression. Make sure we don't see demyelinating plaques. If we do see secondary causes such as MS, a tumor, shingles, or if we identify dental or sinus pathology, then we treat those first before assuming that this is trigeminal neuralgia due to another cause. Next slide, please. When we have someone that we think it's trigeminal neuralgia and we've ruled out some of these other causes, we'll start with the sodium channel blockers. As noted, we'll do either carbazepine or oxycarbazepine. There are some neurologists that will start with gabapentin as opposed to these medications just because the side effect profile from gabapentin is less. It's tolerated better, but the medicines that work the best are these sodium channel blockers. Next slide. And then we can try the other things such as the lamotrigine or baclofen. Baclofen tends to work a little better in people with MS-related trigeminal neuralgia. And then there's combinations or the addition of botulinum toxin as well if need be. Next slide. If none of this is working, that's when you end up seeing someone like me. And then we'll talk about things like microvascular decompression, rhizotomies, radiosurgery. We will talk about microvascular decompression as the main choice since it has the highest likelihood of getting rid of the pain, least likely of causing numbness, and the likelihood of it coming back. But we do have some patients that are older. They may be in their 80s who aren't healthy enough for surgery, or people that have bad hearts that can't tolerate surgery. And in those patients, we often will talk about Gamma Knife as our next step because it's the second best treatment in terms of minimizing the risk of numbness. Its durability is just as good as the rhizotomies. And it doesn't require general anesthesia, and your health status is not as much of an issue. And then if we have someone who is not a candidate for surgery, is not a candidate for Gamma knife, or has failed both of those, then often we'll talk about the rhizotomies as the last option to try to help alleviate their pain. Next slide. Wow, we were supposed to be done in 1 hour, and I think we did that. We got lucky. Are there any questions that we can answer for you?
Yeah, thank you so much, Dr. Field. We had a number of questions coming through the chat. I think we probably only got time for about two or three. Um, so first off, I think someone asked if someone could have both TN and TMJ disorder, or whether or not those two things kind of occurred in isolation from one another.
Yeah, you can absolutely have both. And that again, sometimes the diagnosis of either of those can be somewhat tricky, and so very detailed questioning is very important. Do you have bruxism? Do you grind your teeth? Do you get the pain with light touch to your face or washing your face, or is it only when you're chewing and talking? Does it tend to have like positional components to it? And so you can have both. We've had people with both. The symptoms from both are also a little bit different, though. So more people with TMD or TMJ related disorders will have more of the constant or throbbing or aching pain. They're more likely to have bilateral pain. Whereas with trigeminal neuralgia, we're really looking for these people that are doing fine, they feel great, and then bam, they're hit in the face, and they're like, oh my goodness, what is that? That's the trigeminal pain. They don't have the other symptoms with it, and just touching your face can set it off as well. And so that's how we distinguish it. But yeah, you can have both. There are lots of people who will say they had a dental procedure and that set off their trigeminalgia. So there's some people that think that doing things that could somehow irritate or aggravate the nerve can bring on trigeminalgia. That might be true. There's some of us that also feel that maybe people undergo those dental procedures because they actually have trigeminalgia that's starting to flare up and it's misdiagnosed. They have the procedure and then it really starts to flare up because that's what it was the whole time. So there's a little bit of a debate about that, but truly, we know trauma, dental procedures, and other events can bring on trigeminal pain.
Thank you. That's really helpful and definitely did a perfect job answering that question. Next up, someone asked, they said they understood if their question was a little too narrow for the whole audience, but in March they were diagnosed with TN, but were also 15 years post kidney transplant. This person wanted to ask if their ESRD changed and how they should think about surgical options. Should they pursue that more quickly? They have that kind of complication than otherwise, because that may be able to impact their kidney. Again, I know that, is kind of a unique question. So if you
So,
need
well,
to,
that's a great question, and we would really treat it no different than anyone else. So, when we evaluate someone with trigeminalgia, we still start with medicines based upon the status of their kidney function, would determine what medications may or may not be better for them, and see how they respond. They still can get an MRI using CISS or Fiesta sequencing, and that MRI would not affect their kidney function. So we could see if they have a blood vessel or something compressing on the nerve to help guide them. And if they're otherwise healthy and their transplant doctor or nephrologist says they're healthy enough for an anesthetic, they still could get a microvascular decompression. So it again, it's your overall health that helps to define it, but we still would start with medicines. I don't know if Dr. McGall has any other thoughts or comments about that.
No, I completely agree with that. I think, having that stepwise approach is critical, and choosing medications that don't get metabolized through the kidney might be things that I would consider additionally. Most of the first line medications are more metabolized by the liver, and so it might be safer in individuals like this versus gabapentin, which is more renally excreted. And so, yes, I kind of going through some of that stepwise approach, I think, would be the key.
great, thank you. Next up, and unfortunately, I think we're at about time, so this will be our final question. And again, this is one we get all the time here at the FPA. Someone said they were considering having an MVD quite a distance from their home, which would require flying to that hospital. They were wondering about risks that would result in them not being discharged from the hospital within a few days and them not being able to fly home and what that may look like.
Yeah, I mean, first and foremost, yeah, that's it's a great question. It actually leads to lots of other important considerations. So, if you are going to have this surgery, it should be by someone who has got a lot of experience in managing trigeminal neuralgia from a surgical perspective. When I was trained by Dr. Janetta, we used to see lots of patients who'd had surgery elsewhere and didn't get better. And then when we did the surgery, we often found that the surgeon who did the surgery just didn't know the right place to look, and they would miss the source of the neurovascular compression. So it really should be by someone who's got a lot of experience in doing it. When I say a lot of experience, for those of us who do it regularly, we've all done over 1,000 cases ourselves. Someone who has a lot of experience probably has done at least 200 cases. I think that's probably a safe number to be competent in doing this. And if you have nobody close by who's done that kind of volume, it makes sense to travel to get it done. Most people are in the hospital 2, maybe 3 days. There are some rare exceptions. Yeah, there's always a risk with any general anesthetic that um, you can have a cardiac problem. Could you have a stroke? Those things could all happen, just like with any other kinds of surgery. You could end up having problems with your hearing or weakness in your face or some blurry vision. Although those things really shouldn't prevent you from being able to go home. Um, and generally, when we do the surgeries for patients that are coming from out of town with flying, we usually ask them to stay in town for 1 week after surgery. And then in 1 week, we remove their sutures and we let them fly home after that as long as they're doing well. So if you are being seen someone out of state or far away, you should ask them about this and ask them how long they want you to stay in town. Is there anybody close by if the event there is a problem? And how do they manage that? But for most people, it is safe for them to fly a week after surgery to have the procedure done.
Thank you so much. I'm sure that's something that, other members of our community who are patients can answer as well. So yeah, I think with that, we're unfortunately just about out of time. I want to say a huge thank you to you, Dr. Field, and you, Dr. Mudagal, for your incredible expertise, taking time out of your busy days to share this. We'll follow up with the links to this recorded webinar and hopefully answers to more of everyone's questions. You can always stay tuned to our biweekly bulletin, social media, and emails that come out. And again, just look for a link in your inbox with the recording to this webinar. Thank you so much, Dr. Field. Thank you so much, Dr. Mudal. We really appreciate y'all being here and have a great rest of your night, everyone.